Let me know when. Good afternoon, everyone. Welcome to our Timothy A. Johnson Medical Scholars Seminar Series. We are in our first one for 2024, our fifth for the academic year. And as you guys know, this is our seminar series where we invite actively practicing physicians who also are doing research. And we love physicians such as the one you'll hear from today because they really blend this model of working with patients in the clinic and using their observations in the clinic to inform their research. So we will have Dr. Nick Ryder introduce our speaker today.
Thank you for that. Yes, for those of you who don't know me, and you may not because I've only been here a month, my name is Nick Ryder, new faculty in the Department of HSIS here at VTC School of Medicine. It is a real honor and a pleasure for me to introduce my dear friend, colleague, and a tremendous physician scientist, Dr. Emily McGowan. Dr. McGowan is an associate professor in the Division of Allergy and Clinical Immunology at the University of Virginia. She completed her medical education at Duke, or her undergraduate degree at Duke University, and then spent a year doing research at the National Institutes of Health. After that, she completed her medical education at the University of Virginia, followed by residency training at Beth Israel Deaconess Medical Center, which is part of the Harvard system, as you know. She then came back to the University of Virginia to complete, or actually went to Johns Hopkins, where she completed her allergy and clinical immunology fellowship, and then did a PhD in clinical investigation at the Johns Hopkins Bloomberg School. Her research is focused on food allergy and understanding the mechanisms of eosinophilic esophagitis, the epidemiology, and the pathophysiology of the disease, as many of you have been reading about this week. Her work has been funded by the National Institutes of Health, including NIAID. She's also been funded by the American Academy of Asthma, Allergy, and Immunology, the Food Allergy Education and Research Consortium, among others, including the American College of Gastroenterology. Dr. McGowan is certified by the American Board of Internal Medicine and the American Board of Allergy and Immunology. She is, again, a tremendous speaker. Please join me in welcoming Dr. McGowan.
Great, I'll just push that back. Can everybody hear me? Okay, wonderful. Thank you so much for that very kind introduction. And it's a real pleasure to be here today to chat with you guys about my favorite disease topic, which is eosinophilic esophagitis. So as Nick had mentioned, I have received funding in the past. I've also received some funding from Regeneron that was looking at the phase 3 study of dupilumab and EoE. All that went to the University of Virginia, not to my own pockets. And most importantly, though, there is only one FDA-approved therapy for EoE, which is dupilumab. So other things that I'm going to be talking about today are going to be off-label. So for today, I'm going to kind of take you through 3 different stories. So first, I'm going to go over just a clinical overview of eosinophilic esophagitis, or EoE. Then I'm going to talk about some of our recent work looking at the epidemiology of EoE, in particular in the Medicaid population. And then finally, I'm going to discuss some of the known pathophysiology of EoE and then also the potential role of IgG4. And so that's the paper that I think everybody had reviewed prior to this talk. So I love to start this talk off, though, with one of my favorite patients. So this was a 34-year-old guy who came to see me in my allergy clinic very shortly after I arrived at UVA in 2016. So he came in to see me just for evaluation of allergic rhinitis or seasonal allergies. His wife had made him come in because he was like always congested in the spring and the fall. So he came in to see me. He said that he also had some itching in his mouth when he would eat various fruits and vegetables. So his almonds, hazelnuts, and then some fruits. So we did some skin testing and he was markedly positive to everything. So one of my residents actually saw him. I went into the room afterwards and I always like to do just a review of systems. And so I was like, oh, do you have any, headaches, any chest pain, shortness of breath, difficulty swallowing? And he's like, oh yeah, I can't swallow. I was like, well, what do you mean you can't swallow? And he's like, no, I can't swallow. He's like, my entire family makes fun of me. I'm a really slow eater. All of my friends know how to do the Heimlich maneuver because I'm constantly choking on food. And I was like, this isn't normal. Like, that's not something that you should be telling me. And so he said his symptoms were worse when he ate chicken and beef, and he couldn't drink anything without having a glass of water with him. So I referred him to my GI colleague, Brian Sauer, in the adult GI clinic, and he had an endoscopy about a month later, and this is what it showed. And so, see the pointer there. So you can see here, he had this is a big stricture that he had. He had these rings. It's basically called trachealization of the esophagus. Thank you. Because it looks more like the trachea than the esophagus. You can also see pretty faintly here, there are some lines that go more longitudinally that are called furrows. So definitely not normal. He had biopsies taken throughout the esophagus and he had eosinophils throughout. He also had evidence of fibrosis that was present, which is not incredibly surprising because he had had symptoms for about 20 years before coming in for diagnosis. So we excluded other potential causes of esophageal eosinophilia, and he was diagnosed with EoE. So EoE, in general, eosinophilic GI disorders are disorders that selectively affect the GI tract with eosinophil-rich inflammation in the absence of other known causes of eosinophilia. And they can be divided depending on what area of the GI tract that they affect. And so eosinophilic esophagitis, eosinophilic gastritis, eosinophilic enteritis, or eosinophilic colitis. So this is the new nomenclature that was just published a couple years ago. So again, in general, you've got these EGIDs, which are kind of the overarching umbrella. You've got the different areas that are affected, EOG, EON, or EOC. And what I'm going to focus on today is the EoE, which is selectively affecting the esophagus. So I love to think of EoE in terms of the timeline. So this is a really weird disease, in fact, that it was only first described in 1977. This is in contrast to asthma, which was defined by Hippocrates in 400 BC, celiac disease, which was defined in 1 AD. I mean, this is a really new condition. So it was first described in 1977. This is just a case report. And then in the 1980s, there were a number of papers that were published that linked GERD or reflux to esophageal eosinophilia. So for years, people just thought that this was only reflux. In the 1990s, there were 2 case series that finally defined a population of patients who had this condition instead. So they didn't have reflux, but they really had eosinophilic esophagitis. In 1995, there was a pinnacle study that was done by Kevin Kelly when he was at Hopkins, where they took 10 pediatric patients who had this condition and they put them on elemental formula. And they found that 95% of these patients actually responded. So they completely had histologic remission. So this is the first indication that food drives this disease. And so it's kind of a form of food allergy. In 1998, there were the first studies using topical steroids as treatment for EoE. And then in the 2000s, there were a lot of studies that looked at characteristics of EoE. So who was affected, what were the symptoms? And these were primarily cohort studies that were done at large centers where they saw lots of patients with this. In 2007, we had our first consensus guidelines. And then in 2008, there was an ICD-9 code that was implemented. And so this really opened the way for epidemiologic studies using administrative coding. In 2011, we had revised guidelines, and then 13 and 18. And then in 2022, we had our first medication that was approved, which is dupilumab. And just a week and a half ago, it was actually approved for ages down to age 1. So very, very exciting. So EoE is defined, and this is the most recent definition, by 3 things. So there's symptoms related to esophageal dysfunction, eosinophil predominant inflammation on biopsy, so right now defined as greater than 15 EOs per high-powered field, and exclusion of other causes of esophageal eosinophilia. So I'm going to go through each of these individually. So symptoms, they really vary by age. And so our youngest patient at this point that we see in our clinic is about 10 months old, and our oldest patient is 85. And the symptoms really vary depending on the age. So in children, we see more symptoms of feeding dysfunction very early on. Then they have more symptoms of kind of the inflammatory features of vomiting and abdominal pain. And then when they reach their adolescence and teenage years, they start to have more of the difficulty swallowing, which we think of the classic symptoms, so dysphagia and food impaction. In adults, we oftentimes see more of those dysphagic symptoms, so more of the fibrotic symptoms. So dysphagia, food impaction, sometimes they can have chest pain or heartburn. Rarely somebody can present with an esophageal perforation when eating a food that has gotten stuck. So now in terms of the biopsy. So this is what we have: the biopsy findings, and then we also have the endoscopic findings. And so the typical findings that you'll see, again, the trachealization that I had mentioned before. So these are the rings that you'll see here. That sometimes patients will have these white exudates or plaques. It kind of looks like Candida, but then when you biopsy them, they're just chock full of eosinophils. There's also longitudinal furrows, which I think you can see probably best in this picture right here. You can get just generalized edema, so you can't see the vasculature quite as well. And then about 20% of patients will actually have a completely normal endoscopy. So on biopsy, what you'll see are the definition is greater than 15 eosinophils per high-powered field. I will say that number was pulled slightly out of a hat. It's not totally, it's accepted, it's what we use, but I can't necessarily say that somebody with 8 eosinophils is different than somebody with 15. There's other findings that you can find too. So you can see dilated intracellular spaces and basal zone hyperplasia. So there's lots of findings that really are pathognomonic for EoE. It is a patchy disease though, so usually we need to take more than five biopsies in order to make sure that we actually see this. And then finally, secondary causes of esophageal eosinophilia need to be excluded. And so the major masquerading condition is GERD or reflux. So this has actually become, I think, almost more confusing recently because a lot of patients with EoE also have reflux. So it's very sometimes challenging to differentiate what their symptoms are due to. Another one that has come up a lot more recently too is Crohn's disease. And technically you are supposed to exclude Crohn's disease in order to diagnose EoE. But I will say that we and a lot of other groups have patients with Crohn's disease who also have EoE. So their Crohn's disease is in remission on biologics, and then they also have EoE too. And then there's other things too that can mimic EoE. So in terms of the epidemiology, what we know in the literature is that males are typically affected more than females with a ratio of about 3 to 1. Caucasians are typically affected more than other races and ethnicities. It's very strongly associated with atopic diseases. So about 80 to 90% of patients with EoE will have some other kind of allergic condition like allergic rhinitis or eczema or asthma or other food allergies. It also can run in families. So if you have a brother with EoE, your risk of having EoE is 64-fold higher than the general population. And if you have a father with EoE, your relative risk is 43-fold higher. So I cannot tell you how many times I'm in clinic with somebody with a kid, and then we're chatting about the symptoms, and the father or the mother are like, oh, I think I have this. And I'm like, I think you probably do too. You should probably be seen. There's also possible seasonal variation. So we see some patients will have worsening symptoms in the spring and the fall. And in general, the overall prevalence is about 50 per 100,000, or about 1 out of 2,000 patients. The other thing we know about the epidemiology is that it looks like EoE is actually increasing. And so this is a study that was done looking at incidence in EoE in different parts of the country, different parts of the world. And what you can see is that in general, the incidence, of EoE is really increasing pretty much everywhere that you look, except for in this one study in Spain, which I can't explain. But in general, it really does seem that the incidence is increasing. So this raises the question, is this actually truly increasing, or are we just diagnosing this more? Are we recognizing it more? And I think there's pretty good data to suggest that it actually is increasing. And so the first data for this comes from this study that was done by Evan Dellen, where they went back and looked at pathology rates of EoE in Denmark. And so they looked from 1997 to 2012. And what they found was that the diagnosis of esophageal eosinophilia, which is greater than 15 EOs, or EoE, had increased about 20 to 25-fold during that period. They were specifically looking to see if our diagnostic test was also increasing during that time, which they found that it was, which is the endoscopy. So that was, but there was only a 2-fold increase there, as opposed to the 20 to 25-fold increase in the diagnosis of EoE. So the second bit of evidence comes from Cincinnati Children's. So they asked the question, did we just miss it in the past? Is this something that we weren't looking for? So they went back into their pathology databases from 1982 to 1999 and reviewed all of their esophageal slides and said, how many patients were we actually missing? And you can see there wasn't a ton. And really the increase that they were seeing is mirroring what I was showing you in that timeline, that in the mid-1990s, we started to see this increase, and now we're at a point where we're seeing a lot of EoE. So this raises a $1 million question, why? Why is this happening? And I think there's a lot of really interesting hypotheses. And to be honest, we don't know at this point. There's some thought that the hygiene hypothesis could be playing a role. We're a lot cleaner today than we were probably meant to be. And because we're not exposed to those parasites, our immune system is going into that, allergic T2 inflammation. There's changing aerial allergen exposure with climate change. So the pollen seasons are longer and the pollen themselves are more allergenic. There's also changes in our food allergens. I think a lot of us can probably agree that what we are eating today, especially in terms of dairy and wheat, is probably not what we were meant to be eating. And so has that processing changed something about the way we're seeing allergens? Early life exposures, there's some data showing that PPI use in early life may be associated with the subsequent development of EoE. And then I think the most interesting one that has come up recently is detergent exposure. So I'll show you a little bit later, but the epithelial barrier is really important in this disease. And there's some emerging evidence that we are exposed to detergents that could actually be disturbing that epithelial barrier. In particular, our toothpaste has SDS in it, which if you expose mice to toothpaste, the mouse model is amazing for EoE. So I think there's a lot more work to be done in this area before we have a clear sense of what's going on. What we know about EoE, though, is that the diagnosis is typically delayed. So on average, patients will have symptoms for about 5 years before they're diagnosed. It's also considered a chronic disease. And so it doesn't spontaneously resolve. And if you stop therapy, then the inflammation does come back. Luckily, at this point, there have been no other reports of transformation to cancer or extension of the eosinophilia to other parts of the GI tract. So that's something we can at least tell patients, and that we're not worried about those manifestations later. What we do know, though, is that the inflammation, if it's untreated, can progress to fibrosis in most patients. And so if you have symptoms for 2 years before diagnosis, your risk of having a stricture is 17%. But if you have symptoms for 20 years, like the patients who I initially presented, there's a 70% chance that they're going to have a stricture at the time of diagnosis. And so we see here, you've got kind of the normal esophagus that over time has this inflammation. And the body's natural way of dealing with inflammation is to put down scar tissue in terms of allergic inflammation. And so that's what happens in EoE. And so eventually, with untreated disease, you can have this scarred esophagus. So this is the general overview kind of the pathophysiology. So before I get into this, though, just remind me, what is an eosinophil? I know you guys are mostly first-year medical students and are familiar with this, but maybe some other people in the room are not. So the eosinophil is a granulocyte that develops in the bone marrow, circulates in the tissue. It increases during helminth infections and allergic disease, and it's really driven by IL-5s. And it can release a ton of different things in the tissue when it's activated. So cationic proteins and lipids and chemokines. So now going back to the pathophysiology. So the first thing that I mentioned already is this impaired barrier. So we see this very, very frequently in EoE, and this can do a couple of different things. So the first thing that it can do is release some cytokines directly from the epithelial barrier. So TSLP, IL-25, and IL-33. The other thing that this can do, and that then can drive the immune system into this T2 response, culminating in the activation of eosinophils and mast cells, and then ultimately the dysmotility, fibrosis, and disruption of the epithelial barrier, kind of in a cycle loop. The other thing that the epithelial barrier can do is it can allow food antigens to come in. So when the barrier is disrupted, food antigens can travel in where they are basically picked up by the immune system, the dendritic cells, which then skew the immune system again towards a T2 immune response that is antigen specific. So our treatment options at this point, we have a number of them, and I'm going to go through these individually. So our first line therapy is proton pump inhibitors. So these are, in general, very well tolerated. They're low cost, but only about 30 to 50% of patients will respond to this. We then have the options of swallowed steroids. And so the typical versions of this that we use are either an inhaler or a liquid budesonide that we mix with something to make a slurry. This is very effective, but it can, patients can get Candida esophagitis. And so about 7 to 10% of patients will have this. It also can be expensive. Now that Flovent is no longer brand name Flovent has been off the market. Some of our patients are paying up to $700 a month for the Flovent inhaler, which is very problematic. There's also a food elimination diet. So as I mentioned before, this can be driven by food antigens. And so if you take out those foods that are causing the inflammation, then that can also resolve the disease. So we love it when patients do this, but we don't have a great diagnostic test at this point to say this patient's food trigger is milk and this patient's food trigger is wheat. And so it takes about 4 to 6 endoscopies to really identify what the triggers are. So that can be incredibly expensive. It also requires constant elimination of the food, which can be very challenging when it's things like dairy and wheat that they're avoiding. And then finally, dupilumab is the most recent thing that is on the market. This is a great medication. It is, however, very expensive. So it's a once-weekly injection that targets IL-4 receptor alpha, and I'll show this in a couple slides, but it is incredibly expensive. It's about $90,000 a year for the EoE indication. So this is dupilumab. So it targets, again, the IL-4 receptor alpha, which downregulates or stops the signaling both from IL-4 and IL-13. So this was a study that was published in the New England Journal in 2022 that forms the basis of the approval. And so basically they had 2 different parts. They had part A and part B, where part A, they had a smaller sample size and only had 1 dosing of dupilumab. Then they found that that worked. So they went into part B where they had 2 dosing regimens. And what they found was that essentially in the patients, so this is, the pointer's not working anymore. So this is looking at histologic remission. They found that both of the doses led to histologic remission. However, only the weekly dose actually led to symptomatic improvement, which is why the FDA ended up only approving weekly dosing of dupilumab. Oh, thank you. Awesome. Yeah. So that's the every other week dosing, and that's the weekly dose. And so that's the only one that was improved over the placebo, which is right here. So this is our treatment algorithm at this point. And so the first thing that we do is we have the patient with esophageal eosinophilia. So we exclude other diagnoses and consider those. And if those are excluded, then we have the diagnosis of EoE. So then what we do is typically we will start the proton pump inhibitor. So we'll have a shared conversation with the patient, typically with me and the gastroenterologist and then the patient, and come up with, what is the best first treatment option. Usually it's the proton pump inhibitor, only because this is over the counter, generally generally very safe. And then if that doesn't work, then what we do is go to the other therapies. So once we've kind of optimized their therapy, and that may be that they go on one of these, or sometimes it's even a combination. So sometimes they'll go on solid steroids, but still have a little bit of inflammation. And so we'll restrict milk from the diet. Once we've come up with a point where their disease is under control, then we maintain it. And so we try to get them on the lowest dose of steroids that we can. We try to get them on the lowest dose of the proton pump inhibitor. We try to get them on the least restrictive diet. And then whatever we've gotten them on at that point, we try to maintain over time. So going back to some of the other therapies that are in the works right now. So cendakimab is a monoclonal antibody that targets IL-13. This is currently in a phase 3 trial. I think they've seen some pretty promising results so far. So we're very hopeful that this is going to be another treatment option. Tezepelumab is a monoclonal antibody that targets TSLP. This is another one that we've been, currently in a phase 2/3 study. And so we haven't seen any of the data yet with this, but we're optimistic. And then there have been some studies looking at anti-IL-5, which targets the eosinophils specifically, which interestingly led to histologic remission. So the biopsies looked beautiful, but the patient still had symptoms. And so this has really raised the question, we call it eosinophilic esophagitis, but when you take out the eosinophil, there's still something going on there. So is it the mast cell? Is it the T cell? Should we call it allergic esophagitis? I'm not totally sure, but I don't think it's necessarily the eosinophil that's driving it. So now I'm going to shift gears a little bit and talk about some of the research that we've done. So this first project is looking mostly at the epidemiology of EoE. So prior to kind of shifting over to the eosinophilic esophagitis field, a lot of my research had been looking at disparities in food allergy diagnosis, so things like anaphylaxis. And we know that there is disparities exist in food allergy diagnosis and then also asthma morbidity based on among impoverished children. However, our understanding about the association between poverty and urbanization and EoE is very poor and remains very poor. Also, I mentioned before, we have the ICD-9 and now 10 code for EoE. And so a lot of administrative studies had looked at the epidemiology of EoE using those codes, but none of those studies had included the Medicaid population, which in general is more impoverished than other populations. And so we asked the two questions: what is the prevalence of EoE in the US Medicaid, pediatric Medicaid population? And is there any association between EoE and poverty and urbanization? And so to look at this, we looked at the Medicaid populations. There were 19 million children. This was in 2012. And in that 19 million population of children, we found about 5,000 cases of EoE. And so the overall prevalence estimate was 25.74, which is a little bit lower than what we've seen in other studies where it's around 50. We found, again, this same thing that's been reported in other studies where there's about a 3-to-1 ratio of males to females. And then interestingly, we found this very striking inverse relationship with poverty. And so this is zip code level poverty. And so just to orient you, 0 to 5 means that 0 to 5% of that zip code is in poverty. Whereas if you go down to 25 to 100%, that's more impoverished. And so you can see here the prevalence of EoE just went this stepwise decrease from how more affluent neighborhoods down to the more impoverished. So this was a really striking finding. And so we then said, okay, could there be other things that are causing this? And so we accounted for sex and age and race, ethnicity and state and urbanization, and we still saw this association. So anytime I see something like this, makes me wonder, is this actually something that's protective, or are we just not diagnosing those people who live in more impoverished communities? So the other thing that we found was that the more rural you lived, the less likely you were to be diagnosed with EoE as well. And this data was actually in contrast to some of the other studies that had been previously published, where they found that there was a higher risk in rural populations. And so these results garnered the attention of the National SIGR group, which is kind of like the Eosinophil GI Disease Consortium. And so they put out a reply to our manuscripts and said, is it possible that this could actually just be due to disparities, health disparities? And so what they did was they went to the same year, which was 2012, and they went back to NASPGHAN, which is the Pediatric GI Association, and got the locations of every single pediatric gastroenterologist in the country. And they plotted them on the map. And you can see there's entire states, like Wyoming does not have a pediatric gastroenterologist in the entire state. And so so we wrote back and we said, yeah, we totally agree. We think it's absolutely possible that disparities in terms of access to health could be playing a role. But then a really fun thing happened, and we actually were able to join our data together and collaborate. And we put the data set together and we said, how far away do these kids live from the pediatric gastroenterologist? And what we found is that that was totally what was going on. And so here, just to orient you again, this is our initial model here, where we found this protective effect of living in rural areas, micropolitan and small metro. But when we adjusted for the distance to the healthcare provider, that association went away. So maybe a tiny bit here, but it still crosses 1. And then here and here, you can see the association is just gone. Interestingly, though, that association didn't go away for poverty. And so it didn't matter how far away you lived from a gastroenterologist, there still was this inverse relationship with poverty. And so the lesson here is that the protective effect of living in the rural environment was explained in our study by distance to the pediatric provider, so likely underdiagnosis. However, the protective effect of poverty didn't change. And so yes, it's possible that there could be some protective environmental exposures in the impoverished communities, but I think it's more likely that these are just other barriers to access to care. So we know that providers will, even though they have insurance, Medicaid, a lot of providers don't accept Medicaid. So it's possible that they don't have the access to specialty care, even though they live next to, close to somebody. It's also, you have to take off work to get to appointments. You have to pay for an endoscopy to be diagnosed with EoE, which is incredibly expensive. There's also distrust in medical providers in various communities. And so all of these things, I think, could be playing a role in our findings. So I think this raises the important question, though, like, how many people are we actually missing with EoE? So we've seen now this access to care may be an issue, but there's other reasons to suspect that there's a lot of people walking around with EoE that we're not diagnosing. So as I mentioned, the diagnosis requires an endoscopy. That's anesthesia, that's expensive, it's time off work. There's lack of access to specialty providers. There's other financial barriers to care. In general, in addition, the symptoms are gradually progressive. So if you remember that patient who I presented initially, he was just modifying the way that he ate in order to minimize his symptoms and went on for decades with these symptoms before coming in to see anybody. And then finally, we rarely ask questions about dysphagia, right? I mean, how many people go around and ask other people how they're eating or notice if somebody's taking a longer time to eat or drinking, using more water? We don't really talk about this that much. So, ideally, we would have gone into a rural population or into an impoverished community and said, okay, let's see who we're missing. But we can't do that yet because it still requires an endoscopy. And so our first step in this was to say, okay, well, let's go to a population that we have access to, which is our allergy clinic. And what is the prevalence of EoE symptoms in our allergy population? Again, this is a high-risk population because about 80% of patients with EoE have other allergies. And do any of those patients have undiagnosed EoE? So to do this was led by one of my allergy fellows who was working with me, as well as Emily Noonan, who was my research coordinator, who's now doing an MD PhD at Temple. And what we did is we went into the allergy clinic and just surveyed 100 people. And we took patients who had asthma, allergic rhinitis, IgE-mediated food allergy, and eczema, and gave them a validated questionnaire to say, how many of you have symptoms? And we compared it to a control population that was unselected adults who were coming in for a separate study looking at a COVID vaccine. And so these patients didn't have allergies and were in general just a healthy population. And we found some really striking findings. So we found that 27% of the patients said they had trouble eating solid food in the last 14 days. 41% said they had coughing or choking when swallowing food. 32% said they had pain or discomfort when swallowing food. And this is in contrast to the control population where essentially 2% max had these symptoms. Most strikingly, though, 12 patients in this population said that they had food was stuck in their esophagus for more than 30 minutes in the last 12 months. And again, these are people who are not coming in for evaluation of EoE. These are just people who are coming in for other kinds of allergies. And so we then took that population and we did a minimally invasive diagnostic test called the cytosponge. So the cytosponge, this is it. It's basically like a Brillo pad that's encapsulated in this capsule and attached to a string. And what you do is you swallow the capsule, and then it's like one of those toys you used to have as kids, where you would leave it in water, and then a couple minutes later, like a dinosaur or a star would come out. But instead, it's a Brillo pad. And so this is me doing it, and this is the pediatric gastroenterologist who I work with, Barrett Barnes, doing it. And so you wait 7.5 minutes, and then you pull the string out, and it does a gentle scraping of the esophagus. So you then can take the cells that come from that and create a cell block and section it and stain it for eosinophils. And so this is a patient of ours who had the cytosponge that was done right before his endoscopy. So you can see on the endoscopy, there are lots of eosinophils represented here by the arrows. And then this is what we see on the cytosponge. It's basically a cytology sample. And so you have to look for the area that is the stratified squamous epithelium of the esophagus. And then you can look for eosinophils in that area. And so we went back to our patients in the allergy clinic, and we took those who had typical symptoms of EoE. So of those, there were 44. We invited a portion of them back for the cytosponge. Not many accepted, but some of them did. And so we were able to do 5 cytosponges in this population. Of the 5 cytosponges that we did, one of them had EoE. We went to confirm it on biopsy. He had an endoscopy 2 weeks later, had confirmed the diagnosis. He has gone through a PPI and swallowed steroids, did not respond histologically, and actually ended up on dupilumab. We had another patient who had, when we looked at the cytology, there was actually striated muscle, which according to our pathologist was actually a piece of steak. And this patient actually felt dramatically better after we did the cytosponge. So it was almost like a therapeutic cytosponge too. He then had a confirmatory endoscopy. He had one eosinophil on his cytosponge. He had an endoscopy that did demonstrate some of the distal esophagus, but it ended up being more reflux. And so he responded to a proton pump inhibitor, and we think he was reflux, not EoE. We additionally there were 3 other patients that after we asked them about these symptoms, they went and had an endoscopy for clinical care. And 2 of those patients ended up having confirmed EoE. So it's a limited sample size, but going back and weighting our estimates, we ended up with a weighted estimate of about 8 to 16% of our allergy patients who may have undiagnosed EoE. So lessons for this. So the prevalence of EoE symptoms in allergy patients is very high. And there is likely undiagnosed EoE in patients who have other allergic conditions. And so as internists and medical students and allergists, when we're seeing an allergic patient, we should always ask about symptoms of dysphagia, because again, a lot of people minimize their symptoms and won't come out and tell you that they have them unless you ask. All right, and so in the last portion, I'm going to talk about the G4 study, which I think, again, a lot of people are familiar with now from the paper. So we know, as I mentioned, EoE is driven by food antigens. And so milk, wheat, egg, and legumes are the top 4. But the mechanisms of how these foods induce inflammation and EoE is still unknown. So for example, this inflammation is in contrast to, say, the child who has anaphylaxis to peanuts. We know that is IgE mediated. IgE is binding to those food proteins, binding to the mast cells and basophils and causing a ton of release of, other proteins. That's not what's happening here. So this is not immediate inflammation. This is more delayed over hours to days. And because we don't totally understand this mechanism, we don't have diagnostic tests to identify food triggers in individual patients, which is a critical knowledge gap in our field. So our interest in G4 began with this study that was back in 2014, and it's a beautiful study. And every time I go back and read it again, there is something different that I'm gleaning for it. They were really thinking of everything when they did this in 2014. So this study was initially designed as a trial to look at omalizumab, which is a IgE targeting monoclonal antibody. So they were looking to see whether that could treat EoE. And they found a couple important things. So first, they found that omalizumab did not work. So that really shed light on the fact that this is not an IgE-mediated condition. The second thing that they found is that there was all of this IgG4 deposition, so you can see here in red, in the biopsies of patients who had active EoE, and this is a control patient here. So they then looked in the serum, and they also found high levels of IgG4 in the serum. They also used electron microscopy and found that these deposits looked like they were consistent with immune complexes. So since this time in 2014, a number of studies have looked at IgG4, and consistently we are seeing a lot of deposition of IgG4 in the tissue. And so the same study that I just showed you also looked at plasma cells and found IgG4 secreting plasma cells that were in the deeper tissue layers. They also found subsequent studies have shown that G4 can be used to distinguish those who have reflux from EoE. Our group has shown that if you look at serum markers of IgG4, that patients with EoE have markedly higher serum food-specific IgG4 levels than controls. And then other studies have looked at the production, so basically G4 levels and then other cytokines, and have shown that G4 correlates with disease severity in EoE. So this, from an allergy perspective, though, is really intriguing because we, as allergists, have always been taught that IgG4 is protective. So IgG4 is a good antibody. IgG4, if you put people on immunotherapy, IgG4 is what goes up. And so we think of it as being kind of protective and dampening the immune response. And so having something that now could be possibly involved is just antithetical to how we typically think of this. So IgG4 is kind of unique. It's the least abundant of the IgG subclasses. It increases in response to IL-4 and IL-13, but it also increases in response to IL-10, which is, we think of with T regulatory cells, so being, again, at a protective response. It also has this flexible hinge region that allows Fab-arm exchange. And so here, with the antibody here, it basically has these two cysteine residues. So normally antibodies should be, tightly bound together. They don't break apart. But with IgG4, because of this cysteine binding, it can break apart. And so you can take the two arms that used to be directed against, say, milk, and break apart, and now you've got it rejoining with something that's directed against wheat or cat or dust mite. And so because of that, it's thought to be functionally monovalent and doesn't typically form immune complexes. It also doesn't activate complements, unlike some of the other immunoglobulins. But interestingly, IgG4 has been shown to be pathologic in other diseases. And so the best illustration of this is pemphigus vulgaris, where IgG4 is actually the antibody that is binding to an epithelial barrier protein that causes the blistering skin reaction. It also has been implicated in membranous glomerulonephritis. And there's a condition called IgG4-related disease, which is a progressive fibrosing condition. So a lot of these things, at least the fibrosing part of things, is very consistent also with what we see in EoE. So our question first was, why is IgG4 present in the tissue? IgG4 is a soluble molecule that should not be in the tissue unless it's bound to something, so either an allergen or another cell. And so to look at this, our hypothesis, was that it's forming immune complexes with food. So to look at this, we use the UVA cohort. So this is a cohort that I had established back in 2017, shortly after I came to the University of Virginia. This was also at the same time that I was pregnant with twins and building a house. So there was quite a lot of stuff that was happening in the spring of 2017. Patients are eligible for enrollment in the cohort if they're either seen in our multidisciplinary EoE clinic or if they're getting an endoscopy for evaluation of suspected EoE. And at the time of the biopsy, we get tissue samples, serum, we get urine and saliva, and then we collect detailed information about their endoscopic findings. And so to first look at this, two of the fellows who were working with me, this work was started by Rongxi Li and then extended by John Metternach. The first thing that they did was they took a patient and stained for IgG4 in wheat. And so this is IgG4. This is looking at an antibody against gliadin, so wheat protein. And then this is when you put the two images together. And so any area where there's yellow is area where there is overlap between the two antibodies. And then the blue is DAPI, which stains the nucleus. And so you can see here these kind of beautiful deposits of yellow here showing the co-localization between IgG4 and wheat proteins. So then we said, okay, we're seeing it with wheat, but that's not usually the primary driver in EoE. So milk is the primary driver. That 80% of patients will have milk as a trigger for EoE. So we said, okay, we're seeing it for wheat. Can we also see this for milk? And sure enough, that is what we did. And so again, the red is the milk proteins, green is IgG4, and then all of these yellow areas are areas where the co-localization is there. So then we said, okay, well, we see this in active disease, but what about in remission? And so we take the same patient who is in remission on swallowed steroids, and this is what we see. So there was a tiny bit of green here, like a little bit of G4. I'm not sure if that's background or real, but definitely very different than what we see here with the co-localization. So then we say, okay, well, we see this for one patient, but what if we extend it to more patients? And so for this, we took 20 patients, and we had 10 of them who had active disease and then had paired samples when they were in remission on a diet, and 10 patients where they had active disease and then remission on swallowed steroids. And this is what we saw. So this is part of the paper. So we basically have the active EoE patients. We have the same patient who's in remission on steroids. And again, you can see some deposition, but it is definitely less than what they had previously. And then this is what we see on the diet. They're in remission on diet. And then this is just taking all of the kind of doing a mathematical correlation to see what the correlation is in the pixel intensities. And we saw that it was different between the active disease, the remission, and the controls. And so this is all, that has been published in the paper that was published past summer. So then we said, okay, we're seeing this co-localization, but that doesn't actually show that the G4 is binding the food proteins, right? Or the other allergens. It just shows they're in the same general area. And so to look at this, we did two different techniques. So the first thing we did was co-immunoprecipitation. And so what we did here was we pulled out IgG4 in the tissue, and then we did a counter stain looking at a milk protein, which is beta-lactoglobulin. And we found here that when you pull out the G4 and you counter stain, that in the patients who had active EoE, it was binding milk. But this kind of takes a lot of a priori thoughts of, okay, milk, wheat, egg, soy, whatever, you'd have to do co-staining for everything. So we said, let's try a different approach. And let's take out IgG4 and then do mass spec and see what it's bound to and identify all the different proteins. And so we did that in a patient, pulled out the IgG4, did mass spectrometry. And in this particular patient, this is just a representative sample, he had cow's milk, almond, tuna, sesame, tilapia, peat, cherry, and dust mite. Okay, so a ton of different proteins that were bound to the G4. For this patient, though, this was actually really clinically important because, again, we think of EoE as being driven by food, but this patient had dust mite as one of the things that was bound to IgG4. And we do see a population of patients that don't respond to the diet. And so this patient was saying, I could have gone on this massive elimination diet and never had remission because if dust mite was there and actually doing something, the diet wouldn't have helped at all. So then we said, okay, we're seeing that it's binding food, but what is it doing? And so for this, we went to this technique called auto stomp. And so Sarah Ewald is a collaborator at the University of Virginia who developed this really awesome and elegant technique where you essentially take a tissue and you identify an area of interest, and then you map it and use 2-photon cross-linking to essentially tag the proteins that are in the area of interest. And then you can use strep-avidin precipitation to collect the sample that you're interested in and then use mass spec to see what's there. And so we did this for G4 to see what's in the location with the IgG4. And so this is a sample here. So we had these IgG4 areas that were of interest. And here you can see that this was the threshold. We created the map. And so these are the areas where the proteins were all pulled out. And we found two really interesting things. So the first thing that we found was that this is the area of G4 compared to the flow through, which is basically the rest of the tissue that was not by the IgG4. So these patients, this patient in particular, this is one representative sample, had a ton of food proteins. Look at these are all food proteins that were all around the area of the G4. Whereas in comparison, there really was not much at all in the flow through. These proteins in particular were significantly elevated. ARA-H3 is a peanut protein, and then BOSD12 and BOSD4 are both milk proteins. Again, milk being the primary driver in EoE. This patient in particular had anecdotally felt that peanut was one of his triggers. I don't know anymore because he's on dupilumab, so I can't tell what's, if it's a trigger or not, but that was very interesting. The second thing that we found is that there were a ton of eosinophil associated proteins that were located right by the G4. And so here, MBP, EPX, and then ECP are all proteins that are secreted by eosinophils when they are activated. And we found that these were specifically located around the areas of the G4. So and then we did it in a couple other patients and said, okay, can we identify specific foods for individual patients? And we can see that each patient had a different profile. So this patient had wheat and milk. So wheat and then beta casein is BOSD8. And then this patient had soybean and tropomyosin, which is a shrimp or dust mite protein. And so is it possible that we could use something like this to identify food triggers in EoE? I don't know yet. I'm hopeful that maybe that's the case, but I'm not sure yet. So then we submitted this paper and we had this amazing reviewer who wrote back and they said, I think this is actually an opportunity for you to show us that the G4 is either on or in the eosinophils. And, we got this back. This is our second revision. We're like, oh, really? We just want to publish this paper. We just want to be done. But I'm so glad that they asked for this because I think this is this was really enlightening when we ended up finding the slide. So we had already done some immunofluorescence to confirm our findings of showing EPX in association with the G4. And so that's what this is looking at. So the G4 is in green, EPX is in red, and then any area where they're co-localized is in yellow. Luckily, on immunofluorescence, eosinophils are really easy to see because they have a bilobe nuclei. And so these are eosinophils here, here and here. And as you can see, there's a ton of co-localization of the IgG4 and EPX with the eosinophils. I don't know at this point, looking at this, if this is IgG4 that is on the eosinophil or if it's IgG4 that is in the eosinophil. I don't know. And that's part of what we're kind of looking at moving forward now. So putting this all together, this is what we think is possibly happening. So again, we got the impaired epithelial barrier that we know is present in EoE. This is allowing the food antigens to come into to where they're exposed to the rest of the immune system. We know that there's two underlying T cell populations that are really prominent in EoE. One is a pathogenic effector Th2 cell that secretes all the cytokines that we know that T cells secrete to basically activate the eosinophils and mast cells. At the same time, there is this Treg-like T cell population that has been shown by the Mark Rothenberg group at Cincinnati Children's. We suspect that this is secreting IL-10, leading the plasma cells to secrete IgG4. Now, what we think may be happening is that the G4 could be binding the foods in the tissue. On one hand, it's possible that this could be then directly activating the eosinophil to cause, that the things that we think of with EoE. It's also possible that the G4 is just holding the antigen in place for the dendritic cells to come and pick it up, to then, in the presence of TSLP and other things that we know are there in EoE, could really facilitate the antigen presentation and drive this underlying T cell response. So I don't know. This is what we're currently working to figure out, but I think it's very exciting to see, either way it ends up going. So lesson number 4. So IgG4 co-localizes with milk and wheat proteins in the esophageal tissue of EoE patients with active disease, but whether this is pathogenic is unknown and is currently the subject of ongoing work. So in conclusion, think of EoE when you see an atopic patient with dysphagia, abdominal pain, or food impactions. EoE is less often diagnosed in those with geographic and financial barriers to healthcare access. And IgG4 appears to be binding to food proteins in the esophageal tissue and may be directly activating eosinophils. I do just want to acknowledge, so my division at the University of Virginia is wonderful. Mike Nelson is our chief, who's amazing. Larry Borish has been a mentor of mine since I was a medical student and continues to have his office right next to me. So he's always reading my specific aims. And then Tom Potts-Mills was really one of the people who initially had kind of thought of this idea and has been influential, in leading this project also moving forward. And then this is Barrett, who's the pediatric gastroenterologist who I work with. Tegan's our dietitian. And then this is our EoE team from 6 years ago, almost 7 years ago, because I was pregnant with the twins. Brian Sauer is the adult gastroenterologist who I work with, who's an amazing colleague. And yeah, wonderful. So thank you.
So does the IgG4 clear with dupilumab?
It's a great question. I don't actually know the exact data. Regeneron has all that data and I haven't seen it. I hypothesize that it does because we know that IgE just plummets. So I think it does, but it's also driven by IL-10 and chronic antigen exposure. So I actually don't know completely if it does.
One practical question. We have patients all the time that are on PPIs doing well, but a good percentage can relapse or again, symptom-wise, you can't really tell. How often in those patients that are asymptomatic on PPI would you recommend a follow-up EGD?
So our typical approach, because we have seen the exact same thing and it's been well reported in the literature. So a lot of people will lose responsiveness to PPI within about 6 months or a year. And so our typical approach is if somebody has responded to a PPI, we will bring them back for another endoscopy in a year just to make sure that they are still in remission. And so that then if they are, then we either keep them there or try to decrease the PPI a little bit and see if we can get away with a once-a-day dosing or 20 milligrams twice daily. But you are spot on in that the symptoms don't always correlate with what we see on endoscopy. And so we do try to practice that every time we make a change, that we will go back down and take a look in a couple months and make sure that whatever change that we have made, that the patients are still doing well on and still in remission. I will say the esophageal string test is now commercially available. So we have not yet brought it to UVA, but we are in the contracting phase with, it's all goes to the University of Colorado. So basically the esophageal string test is a piece of floss that's also kind of in a capsule, like we had showed with the cytosponge. But you swallow it, you wait an hour, and then you take it out and isolate the esophageal portion and send it to a central lab. And they will measure eosinophil associated proteins and then create a score to say if they're active disease or not. And so I think with the fact that that's coming around, hopefully that's going to make it a lot easier for us to really assess remission versus not. Yeah.
In terms of the TRS, aside from kind of postulated the model, have you been able to stain for or kind of identify any TRMs in your biopsy samples or histology samples? Because I'd be very interested in terms of kind of seeing if, even if you have like a clonal expansion afterwards, or if you're having kind of when the TRMs are being established, what's the initial catalyst for that first inflammation?
Yeah, and that's a great question. And it is a super interesting population. So we haven't done any staining to look specifically yet. My concern in doing it is I think it's probably deeper in the tissue than where we get the biopsies from normally. If we're biopsying the mucosal layer, that we may not see any with that. But I think it's definitely an important question. They're also a really rare population, so hopefully we'd be able to get them. What we are doing is we now, as part of the R01 that we have, we're basically doing a diet challenge study. So we're getting people into remission on diet only, doing a biopsy, doing an EGD with biopsies, and then introducing milk back, and then doing a repeat biopsy 6 weeks later. And in the setting of doing that, we are taking biopsy samples to do spectral flow cytometry to look at the change in T cell populations during that time, anticipating that we will probably see an increase in these various T cell populations. Hopefully we'll get resident memory T cells there. I don't know, again, because they're a pretty rare population, but we have all the antibodies and things to isolate those that population. So we're doing that in the tissue and then also in the peripheral blood, and after 7 days of milk reintroduction, we got peripheral blood then too, to see if we see an expansion peripherally with the milk reintroduction. So. Yeah, so we definitely do see the increase in TSLP, and there have been some genetic variants of TSLP that have been identified in the EoE population. So yes, so I think it's the same, thinking of the same pathophysiology in terms of asthma. Also, eczema is very similar in terms of TSLP secretion and skewing towards T2. So yes, I think there is a big overlap. Again, kind of getting back to the fact that 80% of our patients have other kinds of allergies. I think there is a lot of overlap in between EoE and other allergic conditions.
So you talked about how patients have a tendency to downplay or mask the symptoms. If you have a patient that's not being seen for allergy or asthma related symptoms, how do you address that barrier to diagnosis?
This is why I want the NIH to fund my study. It's a $1 million question. It's hard to target those populations. Again, you have to do the endoscopy in order to diagnose it. So the hope eventually is that we will have some kind of biomarker like the TTG in celiac disease, where we could measure something non-invasively and say, okay, you are at risk for having this. Let's go ahead and get you an endoscopy and cinch the diagnosis. So there's a couple of things that are kind of promising in that regard that we may be able to move towards, but we're not yet there. And then I think the other big thing is just education of providers and patients, to say, this is something that we're missing. This is something that we need to be aware of. And if you are having difficulties in eating, you need to see a provider. And I think those are kind of the two major things that we need to work towards right now, because yeah, I think it's underdiagnosed, and we're not capturing those populations who aren't coming in to be seen by somebody else.
What I'm wondering is, you have on the slide here the impaired epithelial barrier kind of being the beginning of this problem. Are you considering that mucosal immunity or something deficient in the production of the mucosa could be more related to the cause, and then what we're seeing with the IG4 is a response to the deficiency in the mucosa?
Yeah, another great question. Is the role of IgG4 actually driving the disease, or is it a response from all the other things? And I think that's unfortunately the debate that I have to have at the national conference in 2 weeks, which I'm not looking forward to. So yeah, no, I think there's a lot of things that are driving that epithelial barrier dysfunction. There are genetic polymorphisms in certain individuals, and they make them more susceptible to having it. And then I think I think it's likely mostly the combination of the genetic variants plus environmental exposures that may make certain populations more likely to get that and then drive the inflammatory response. So I don't know at this point I think the epithelial barrier dysfunction is critical to this disease. And if that is not being adequately treated, nothing else is going to work in terms of treatment. Yeah.
In terms of pediatric diagnostics, I notice a lot of those the symptomology overlaps with developmental disorders like neuro and muscular. Do you think EoE is a comorbidity? Is it getting overlooked by pediatric doctors because of developmental disorders? Or are these diagnostics happening in otherwise typically developing children?
Yeah, I love that question. Because I will say that our pediatric EoE population is different than our adult EoE population. We see a ton of autism and developmental delay in our pediatric patients. We did a study a couple of years ago. We had 9% of our pediatric population has autism, and about 30% have developmental delay. And I think a lot of patients with underlying neuroatypical behaviors also have feeding difficulties, and there could be EoE that could be contributing to some of that in those patients. So I think it's really important to have a heightened degree of suspicion in those pediatric patients who are coming in with other feeding difficulties who also have neurodevelopmental issues, to really screen for EoE and just make sure that that's not contributing to what's going on too. I don't know at this point whether it's a shared pathway that's causing both, or if it's that for example, the toothpaste, we know, maybe there's some environmental exposure that is coming differently in kids who have neuroatypia that's then causing this cascade. I don't know.
I had one as well for you. I was curious, and correct me if I'm wrong, but I think on one of your slides you mentioned that early use of PPIs could increase the risk of developing EoE over the course of somebody's life. I also noticed that PPIs are used to treat EoE, and I was wondering if you could kind of make sense of that clinically or mechanistically.
I wish I could make sense of that. So the studies, there have been a couple of studies that have looked at basically PPI shortly after birth, and a number of those have shown that there's an association in those studies between the use of PPIs and then the subsequent development. They tried to correct for basically the PPIs being used as early treatment, but that's very challenging to do in a retrospective cohort study. So I don't totally know if that's just that these are kids that were having early presenting signs, that were actually being treated with PPIs, or if there's something about the PPIs changing, like the gastric pH and antigen presentation of the foods, that could be driving EoE. That's still a big question in the field. Yeah.
My question is, the patients in remission, if they get reintroduced to the milk or the meat they were taking, do they go back to EoE?
Yeah.
And,
Go on.
And if these specific strand of cow milk protein is taken off dairy or milk, are they going to still react to it? Like maybe we take BOS5 out of the milk, are they going to react to it?
Yeah, so we do know that unless the patients are being treated with some other kind of therapy, so if for example, they're on a proton pump inhibitor, solid steroids, or dupilumab, so medical therapy, if they're on those things in remission, they can oftentimes eat the foods and not have a problem because you're kind of treating the inflammatory response the other way. If you're treating them with diet, with milk and wheat avoidance, and then they introduce the foods back and that's a trigger food, then the inflammation does come back. So we have not yet seen, I haven't yet seen in my population anybody who's like totally outgrown EoE and able to introduce it back later. There's some studies looking at possibly doing epicutaneous immunotherapy as a way to treat the milk specific response. It's not widespread yet, and I haven't seen many of the results from that, but there could be a way. And then your second question was, what was it? Oh, if you modify the milk. Yeah, this gets into a really interesting question about what is milk that we're drinking, you know? I didn't show the slide, but one of my colleagues has the slide of what goes into the processing of milk, and it is a little bit insane. So we have a hypothesis at this point that the way that milk is processed today makes it more allergenic for this disease in particular. In particular through the homogenization process that may change the way the proteins are exposed to the immune system. So I don't know if you could take out a specific protein because a lot of patients have reactions to many of the different proteins in milk. So I don't know if and each patient seems to be a little bit different. So maybe some reacts to BOSP4, another may react to BOSP8. So I think it would be challenging to take out individual pieces of the protein, but possibly maybe the way that we process it needs to be re-examined.
I have a question. Since there's overlap between asthma and allergy, do you have an increased risk of asthma in your EoE patients?
Yes. So yes. There's an increased risk of asthma in the EoE populations, and we have a lot of the pediatric patients with EoE who have very severe asthma. There is some emerging evidence that just like the way we see with allergic rhinitis, if that's active, the EoE could be worse. We have some emerging data that the more active the asthma is, the worse the EoE could possibly be too. Yeah.
But some of your increase in symptoms, does it correlate with higher incidence of use of spacers in the population?
That's an interesting question. Interesting. I don't know. That's an interesting thing to look at. Yeah. No, that's interesting. Yeah, what we are doing right now is one of the pediatric pulmonologists, Jerry Teague, who I work with, does quite a lot of bronchoscopies on children with severe asthma. And a sizable number of those patients who have the bronchoscopies have the aerodigestive procedure done at the same time. So they'll get the endoscopy and rhinoscopy. There is a large proportion of those who end up getting diagnosed with EoE in that setting. And so we are looking at that population a little bit more now to say, what's different about these kids versus others. Because the literature on the asthma EoE overlap at the moment is actually fairly limited, which is somewhat surprising because both, asthma is a very common childhood condition. You think there would be more studies on it. So. I probably just added to that worry too by this talk. Sorry about that.
Fantastic.
Yeah.